This week, we present a special edition of Conversations on Healthcare. We talk with one of our own, our beloved Dr. Carl Lecce, who has just retired after 4 decades with Community Health Center here in Middletown, Connecticut. I think through this chat, you'll learn more about the history of community-based primary care for the underserved. Enjoy this conversation. Welcome to Conversations on Healthcare. I'm Mark Masselli, and I'm joined by Margaret Flinter, and we are here interviewing one of our heroes, Dr. Carl Lecce. And today is his last day after 45 years of service at the Community Health Center. And we couldn't be prouder of our relationship and partnership with Carl. He started back almost 45 years ago in a week or so, but you and I met for the first time back in July 1978 when you were just finishing up residency. But I do want to just sort of go back and ask a couple of questions. Tell us, you were born in Pennsylvania, whereabouts?
Williamsport, Pennsylvania.
Williamsport, Pennsylvania. And went to high school?
In a smaller town about 5 miles away from there called Montoursville, Pennsylvania.
Okay. And from there off to Columbia University for
undergraduate.
I should note, I heard recently on a football scholarship. I don't know, Margaret, you heard that.
I mean, that's how I got interested. I didn't pan out to be a star on the football
field. Well, not on the football field.
But you got to Columbia and became a star.
And then you went off to University of Pennsylvania at Hershey for medical school?
Yeah, actually, Penn State at Hershey for medical school. Yeah.
Hershey for medical school.
Yes.
Was Hershey new then?
It was about 1 or 2 years old.
1 or 2 years old.
And it was the reason supposedly that it existed was to train primary care physicians.
That's right. It was really a remarkable innovation that the Hershey family put a lot of money in, built that beautiful hospital, large medical school out there.
Yeah.
And then from there, how did you hear about, you came to Middletown 3 years before you started, so in 1975, how did you hear about the Middlesex Family Practice Program?
Again, that was only 1 or 2 years old at the time, and only because a bunch of my friends from medical school were coming to New England to do residencies in various things. And so I just sort of started looking in New England and, Middletown, it looked like, maple trees in the autumn with congregational churches.
College town, right? Yeah.
College town. I knew a good friend of mine from Middletown went to Wesleyan, or from Hershey went to Wesleyan. And so I met some people there that had been at Wesleyan. And, it seemed like a nice sort of New England town. So I picked it.
But Carl, timing-wise, this is really the dawn of family medicine as a specialty, right?
It was pretty close.
Tell us a little bit about that. It had gone from general practice to family medicine with its own specialty residency training.
They carved out their own specialty, their own certification, just to make it a sort of a more credible way to work and specialty. It was an interesting thing when me and my colleagues were applying for residencies. The dean of students at Hershey told us all, and we were thinking of where to go to residency programs. And the big divide was, do you go to an academic medical center or do you go to a community hospital? And, those of us that were interested in family medicine kind of leaned towards community hospitals. And even at Hershey, the dean of students, who was an academic, said, that's the biggest mistake of your career. You really need to be in a tertiary care hospital with other residents. And so it wasn't encouraged, but most of us disregarded it and went anyway to community hospitals.
You were real pioneers.
Absolutely.
Because that was a whole new area. Right. So you come to Middletown. Where do you, for those of us in Connecticut, where in Middletown did you end up living?
Portland.
I ended up on Ridge Road, which was about 5 minutes from the hospital.
Yeah.
Rented an apartment there.
Oh, that's great.
And I remember exactly, it was $90 a month.
Oh my God. Well, times have changed. This might be the daily rate.
That's right.
But then you come to Middlesex, very creative initiative. D. Brown, I forget who was doing who was the lead at that point.
I think he was the head of the residency.
Yeah, that's right. Yeah. And you had local practitioners who were all engaged in that, pediatrics, internal medicine. What was the mix there?
Yeah, I mean, most of it was 3 years. Most of it was in the hospital, except for our model family practice unit.
As part of the hospital.
Yeah, which was next door to the hospital, but owned by the hospital.
Yeah. Still going today?
Yep. Actually, I think not quite in the same place, but very close to the same place. And then we did some training in various local practitioners' office. I remember there was a dermatology rotation in the dermatologist's office and general surgeon in the general surgeon's office. And that's kind of how it went.
Did it have OB at that point, or was that something that came later?
It had OB. The OB department at Middlesex wasn't wildly enthusiastic about family doctors doing OB. And I mean, it sort of wasn't a tradition in New England with Yale and Harvard, and they sort of dominated how medical care was conceived.
But one of the things that was unique was you weren't competing with other residents for intensive care experience or for pediatrics, newborn nursery, or any that was the dean back at Hershey maybe didn't fully appreciate what a challenge that is in the academic medical centers. And family medicine, trying to do that at Yale would not have been a possibility, at least at that point in time. So you had great insight.
Yeah, it was. Yeah, and it was decent training. I don't have any qualms about it.
Yeah, for those of you who follow conversations on healthcare and follow the work that we've been doing, obviously you hear now about the health center, our work, not only in Connecticut, Margaret, we have 200 locations, care for 150,000 people. We have offices for our training program, NEMA, the National Institute for Medical Assistance in Denver, in Southern California, the Consortium, which is a program that Margaret started as the first nurse practitioner residency program 15, 16 years ago, and now an accrediting body. And then we also do specialty care around the country to about 4.5 million lives through our Confer Med. And then in our DC office, we have Weitzman Institute, which is our policy arm. But the reality was when Dr. Lecce came to us, we were one small hallway. And I think we had an opportunity to be with Carl yesterday. And he told this interesting story about the advice as he was thinking about where he should go. I want to sort of say that there's bookends to what his dean told him or advisor to what advice he got coming to a community health center. I think many of our listeners, Margaret, are from the federally qualified health center world, of community health center world. They will appreciate this. One of the challenges that we all faced when we were much smaller about, is this the right decision to make? And Carl, maybe you could just tell that story one more time.
Yeah, when I was trying to, when I finally had decided to go, and I was telling people at the hospital where I'm going up the street, and at that time the relations with the hospital community and the community health center were not the best. And it's interesting, the social workers at the hospital said, "Great, sounds like a good idea." And then I
always listen to the social workers.
And I told this one cardiologist, and he said, well, that's fine, but what are you going to do when you grow up?
And you can see what Carl helped us grow over these many, many years. And, maybe just put a little finer point, those of you who remember back to your origin stories, probably some of this reflects. So Carl comes in 75 to Middletown. 72, we start as a free clinic offering dental services first. And we're in a small second floor walk up, and the state comes knocking on our door saying, where's your license? And we sort of asked the question of, do we need a license? Of course we did. And they did an inspection. Turned out our hallways were 1 inch too narrow. We find out later that probably 35 local providers, local physicians, had all signed a letter to the state saying, how is it possible? So when Carl talks about the struggle, there was a struggle, certainly. We all face this at some point. But I say today we have great relationships, in part because of the pioneer work you did.
That's right.
In terms of building a relationship by which we got known for more than just be rabble-rousers, but really for a great practice of medicine, which you did. And I think physicians who are listening here, this is a true champion, 7 days a week, Margaret.
Well, and I think it's important to note that how Carl earned that respect. Of course, you were already known to many people from doing the residency, but if we dial back the arc of time, thinking, on these bookend days of the beginning and where we are today, that was one of the big differences, right? Carl was on call 24/7, but he managed all the admissions, newborn nursery to ICU to wherever in the hospital somebody needed to be. And that was the beginning, I think, of the creation of the community connection between the medical community and community health center, because real relationships developed out of that. And they became, when I joined a few years later, they were friends. Institutionally, there might be challenges, but in terms of the individuals, the specialists, they were friends and colleagues who appreciated enormously that patient seen in the emergency room had some place to be sent to for follow-up, right? The people who are attached. This is pre-Medicaid, except in a very limited way. It's the days of city welfare where you had to go to the town clerk's office and get a little ticket to go see somebody if you wanted to get health care. It was a radically, radically different world. But the medical community at the hospital level really counted on Carl, Dr. Lecce, as the person they could then send patients to and to the community health center.
And Carl, we've moved to the hospitalist program, but I can remember you telling us, and we run Confirm Ed, which does e-consults, but I remember Dr. Lecce coming back and say, I go to the hospital, I have an opportunity to pull the specialist aside, ask them questions, and really have a conversation with them, sort of lost with the hospitalist world. But talk about the opportunities you had just to go back and consult with colleagues, pull them aside and get some feedback.
One of the positive aspects of, working in the hospital, one, you got to know the specialist, and so you got to know who you would prefer to send your patients to and who not. And it was a lot easier just to pick up the phone and call them up and say, hey, can you give me tell me
advice.
What to do here? Now most of the specialists are just names, so I don't know them, So that was one of the things that was lost. The other thing that was lost was sort of a lot of people then and now, they go into the hospital end of life. And so we sort of lost the end of life part of care. I'm not saying I would really, really want to go back.
Sure.
But I think that was one loss of not going to the hospital anymore, of, taking care of patients at the end.
Absolutely.
Anyway.
Margaret, I want to dial back a few more years from that, and maybe you could just walk through the background of what was happening in 1980 with the HIV and what we uncovered, and the work, and maybe hear from Dr. Lecce about the work with the HIV patient.
Sure. Well, as everybody here knows, I came along a few years after Carl in 1980 as a National Health Service Corps scholar assigned to the Community Health Center. My great good fortune to be assigned, and Mark accepting me for an assignment down on Main Street in that one hallway that I always call the original team-based care model, though we didn't quite call it team-based care, but we had everything: dental, behavioral health, medicine, and a home visitor, the forerunner of the home visitation programs for new parents. And I would say, those first few years were tremendous learning, family practice, pretty much what one might have been expected to do. And then we were in the mid-'80s reading the weekly, monthly morbidity and mortality report from CDC about pneumocystis carinii identified in a small group of people in San Francisco. And Carl and I were saying, what is this? And it was very, very short period of time before the AIDS crisis arrived full blown. And Carl, you so stepped up to the challenge on that. Tell us about that, how you remember it unfolding and the work that you did to try and provide the very best that we could for people with limited options.
Yeah, I remember we didn't have like large number of HIV patients, but we had some, and sort of we did the best we could. At the time, it was basically there was one drug, which was AZT.
That's right.
And we used it, and retrospectively, it didn't do anything except make people anemic. And I remember making some home visits on HIV patients. And I remember one young guy, he was like 17 or 18, caught HIV because he used drugs with his father, and got progressively sicker from the usual HIV stuff and ended up dying, and told me when he was alive, I don't want my family to know about this.
Yeah.
And so the family kind of kept questioning me, why is my son not getting better? Why are you not making him better? And I couldn't really tell them. And he eventually, I think, died in the hospital. Anyway, but that was a hard case.
Yeah.
Young, I think he like maybe 18, 19 when he died, something like that. Yeah.
And probably out of those experiences, we formed the Oasis program.
That's right.
Really, they had the supportive
center.
Down on Ferry Street, also down at close to the hospital, right? So
Preston Street.
How were those? How was it to have that support network as well?
That was very helpful to have other people sort of being on the team, helping the patients, and they had groups and all kinds of stuff. So that was helpful.
Yeah, and then we had a first line seat on the advent of testing that was reliable, though a little complicated, of treatments that began to be effective, of the ability to engage with public health and infectious disease, but really led to our developing the specialty here to be able to fully manage HIV care. And of course, we saw the advent in women as well very quickly.
Yeah, then, I mean, from the single ineffective AZT drug, then it became much more complicated with multiple drugs, multiple regimens, resistance. And at that point, I personally sort of handed off to ID people in town because it became a little complicated for me. And then we had a couple of infectious disease people that would come up every week and discuss patients and care. So that was actually a good program at that point.
Right.
It's interesting you say that it was complicated regimes that we had to deal with. Margaret and I just had the opportunity to be at the Aspen Institute, and we had a sit down with Dr. Fauci on the anniversary of PEPFAR.
Right.
And one of the stories he told us was, the regimes were so complicated, and he was off to Africa. The President Bush had asked him to go, and he said, I'll go, and I'm just worried that they just won't be able to keep up with the regimen of medicines and sort of the timing that had to be used. 5
times a day.
Yeah, it was just really incredible. And he came back and said, oh my God, they can manage this. And PEPFAR got born. Right. It was sort of an interesting story.
Just needed the resources.
Just needed the resources. And he came back and sort of said, well, I think here's the amount I think we need. And the president said, after everybody left the room, he said, Tony, come over here. He said, that's a small number. Let's really go all in. He said, and he told Fauci, let me worry about the money. You just make sure the program works. And it was, saved
millions
of
and
lives.
millions of women and babies and men and everybody else.
But it wasn't easy. It was complicated, and then things got better. Sort of on the parallel track, we're also engaged in domestic violence, and we start a battered women's shelter, and really having that relationship of New Horizons again, not in the facility, but a shelter for them. Obviously, over the years, lots of domestic violence issues. As a practitioner, what were the struggles that you faced, and how were having the resources of a battered women's shelter helpful?
Having the resources was great. Before that, there was very little that, at least as a single practitioner or in a small group, that you could do. So having both the physical shelter and the shelter personnel that would, come to the office, make contact with the patients. If it needed to go through the court system, they would help them with the court system. So that was terrific. Yeah. Otherwise, it was just very frustrating because the single person in an office couldn't really deal with it.
Right. Yeah, and gave us a much deeper understanding of the issues, and I think made us better at just recognizing it in primary care, which is a big challenge. We those few years march on, so much happened. I marked the late 80s, beginning of the deinstitutionalization of people with chronic mental illness. We are in a beautiful community. Up on the hill overlooking it is a classic state psychiatric facility that had been there since the 1800s.
On the other hill is Wesleyan University.
On the other hill is Wesleyan. Some similar architecture there, divided by the Connecticut River and Main Street. But it was born of the desire to stop the isolation and stigmatization of patients, which was all very positive, and yet the preparation at the level of the community was not quite so. And I think much fell to primary care and much fell to community health center in terms of responding, and suddenly having the challenge of integrating healthcare with psychiatric care and homelessness. Tell us about what you remember about those days.
Ooh, do I remember? It was a challenge. A lot of the folks would come out of the institutions and they would end up homeless. They would end up using drugs. They would end up that their psychiatric illness would relapse. There was a community mental health center affiliated with the hospital in town. I'm not sure it was up to the total challenge of the times, but they were there. And then at some point we developed our behavioral health.
That's right.
We expanded.
I don't remember when exactly.
Right. Well, we added our child guidance clinic in 86, 87, with a feeling a real need, and became the designated child guidance clinic. But our behavioral health services, which had pretty much served our patient population with a few, one or two therapists.
We had Eileen Schakowsky
from the very beginning.
Early, social worker.
Yeah, but they really expanded in order to embrace the full range of behavioral health services, and really became, I think, one of the foundations which allowed us then so many years later to expand into the schools in such a
And it's kind of interesting. We now talk about warm handoffs, but there was a warm handoff in the hallway
very warm.
Back when you came in 78 that you were able to do that. But team-based care is really something, and we've tried to, when we moved over to our newer building and across the state as we built out facilities, trying to move from what you experienced when you came. You had a solo office. You didn't really have a solo office, but you had a closet. But how was that transition? Because that was really the beginning of this choreography of care delivery that really changed. And geography was important, right? In terms of bringing people together. So you had that older experience of a single office moving into the pods. We'll talk a little bit about that transformation.
Yeah, the single office, looking back on it, was brilliant. It may have just been born out of that's all we had, but the dentist was there and the social worker was there. and then I think we had somebody to sort of help with entitlements and stuff like that.
Mm-hmm.
And then we sort of got bigger, and just by what was available, we had to be in sort of different buildings.
Yep.
And so the behavioral health moved to a building that was about 100 feet away. And they needed the space because we didn't have enough space originally to house them all. And it sort of made a little bit of a difference as far as access and communication and coordination. And then after that, we got our current building where everything then came back together. So it's sort of full circle.
Mm-hmm.
I forget, there was some phrase that we had a parking lot gap between medical and behavioral health. There was some chasm that happened, even though it was like 100 feet away.
So we did, I do remember we did in what we call the bowling alley, which, there was the one hallway, then we moved to the bowling alley.
Right.
We did take a crowbar to the walls between a few offices and create pods as an experiment. That was our kind of intermediary step before moving to our Peace and Health building, as we call it, which really took pods to a very intentional design.
Yeah.
And I think one of the things I've always admired about you, Carl, is territoriality is not part of your culture. Willingness, eagerness to communicate with everybody and to share your knowledge and always have time for questions from people. And the pod really took away any apprehensiveness people had about, can I knock on the door? Sure. Can I go in? There is no door to the pod. So yes, you can.
Carl, maybe we can talk a little bit about the expansion at the health center and the pluses and the minuses of that. We have big fixed facilities from Stanford to Groton, from Clinton up to Enfield, and we're adding new staff, and yet probably in the site that you're in, that means there may be diminished focus of sometimes, but it's also additive of new colleagues that have come in. How was that transition for you? Happened over many years, where you saw the expansion and you developed new colleagues, new medical directors at different sites. But what's your reflection on that? Particularly for so many of the health centers across America are small, mid-sized health centers. Mm-hmm. Actually, the vast majority of them are smaller and might be facing this experience. Any advice for medical directors as you think about the opportunities?
I don't know. I think it went pretty well for me. We pretty much stuck to our local team. We have one meeting a week of the on-site medical directors, so we can talk to each other. Just with the pandemic and everything, I personally think we lost something with Zoom meetings as opposed to in-person meetings. Mm-hmm. But I understand there's lots of advantages to the remote Zoom meetings. Mm-hmm. So, but I think it was okay. I just sort of settled in kind of blindly. Okay, this is where we are now, and this is who we're working with. So we'll go forward.
That's right.
So it didn't. I don't think there was a lot of negative stuff. I think it. Probably one thing I would have liked more is, how are you doing this in Stanford?
Sure.
Mm-hmm.
How are you addressing this problem in New Britain? I think we lost a little bit of that, but anyway.
Yeah, let's shift to what you said was a difficult time, which was the pandemic itself. Yeah. And it really just changed the entire way we did business, and probably will be with us for a long time in terms of how care is. But what were some of your early reflections on March of 2020? And we were, I think in February, had Dr. Fauci on telling us about, COVID's, is it here? We were all focusing on Seattle. Was it Seattle? Yeah. And Dr. Fauci said to us, 20,000 people from China come to America every single day of the week on an airplane. And we said, it's everywhere, right?
Warning.
We're all out in, is there another case in Seattle? But it was it was everywhere.
Right. At the beginning, it created lots of anxiety among, the medical staff. And, one of our colleagues would get a stuffy nose or get a fever, and everybody would be worried, you know, and the testing and the mask, and, you know, weren't quite sure, should be we wearing gowns and gloves and masks, and so lots of uncertainty, lots of anxiety. And then we sort of flipped over to doing everything remotely. So
for a while,
I spent a year at a building across the street,
right?
Huge building,
beautiful like office,
20 desks, one person, you know, talking to people on the screen, and you know, it was doable. Wouldn't be my preference to, you know, do that all the time.
Yeah.
But
we used to send people over to visit you just to keep you from getting too lonely.
So yeah, there's sort of a year sitting alone in front of a computer screen. You got through it, and then things eased up. But yeah, it was the beginning was anxiety producing for sure. Yeah.
Margaret, as we sort of wrap up with Carl, maybe talk a little bit about his role as a preceptor.
Of course.
I think what's important probably to many of the medical directors listening, just training the next generation.
Right. And I will say, speaking as somebody who arrived as a brand new nurse practitioner in 1980, I want to thank you for being the best mentor anybody could have. And again, the level of collegiality, mutual respect, but also just your willingness to share your vast knowledge and all that you had seen was incredible. And I think pretty much from the time I was here anyway, we always had students. We had students from different schools. We had nurse practitioner students. We had some medical students for a while. Developed a great relationship with Middlesex Family Medicine Residency for the OB prenatal program. So they kind of are here and run that. So that's been a nice updating of that relationship. But when we made the decision to start the nurse practitioner postgraduate residency program here at CHC, you, along with many providers, became a preceptor, but you have been absolutely instrumental as a preceptor. And I wonder if you could talk with us a little bit about your experience. Been doing it now for 16, 17 years. Generations have been trained by you.
Yeah, I generally enjoyed it, you know, teaching people, sharing knowledge. I think it happened fairly seamlessly. A little bit prior to that, I would take medical students. An interesting thing about one of the very first medical students I had, they were from UConn, and one of the perks of taking a medical student is, and that was so long ago, they gave you free UConn women's basketball tickets.
Wow.
Because nobody wanted them.
That would be a heck of an incentive today.
Go Huskies.
But it sort of started with a few medical students and then went into the nurse practitioner residency. And I don't know, it seemed fairly natural to me. I don't remember it having a lot of, I had self-consciously do this, it's just, okay, we'll do it. And it's kind of enjoyable, and I kind of enjoy it, they kind of enjoy it. So it works out. 4 hours, you don't have to deal with patients, a week.
Interesting for you. You can go back and look up the things yourself. But we can tell you, and we were just at the consortium conference in Washington earlier this week, and part of the buzz were alums who are all over the country now, several of them running their own programs. Ellie Wycheck out in Seattle, Jessica Horseman in Hawaii, Tanya Tarot starting up a program in New Orleans, of course, our own Nicole Seagriff, who's here at CHC as the clinical director of the program. But everybody talked, they'd all gotten the note that you were leaving. Everybody talked about how important you were to them as a preceptor. And again, the same things that I look back on as formative, the collegiality, the mutual respect, the willingness to share the incredible font of knowledge, because you truly have seen just about everything. We think, you never know in healthcare, but we think you've seen just about everything. And great gratitude, and also role modeling for what it means to serve in that capacity.
Thank you.
And Carl, as you said the word enjoy and retirements or this new chapter, I'm not sure how we define it.
There were several requests yesterday. They expect you to come back in so they can ask their questions.
Your badge activated. But what are your plans? I know you're involved in some environmental issues in town or thinking about those.
I don't have a real structured set plan.
Yeah.
My tongue-in-cheek is I'm going to talk to my dogs and they will reveal it to me. I've talked to people that were retired and I said, how did you figure it out? How'd you work it out? And a lot of them said it took 2 or 3 years to get into it.
Yeah.
Other than that, it's talk about if you're a medical practitioner, your day is really, really structured.
Yeah, and
every
very
15 minutes.
Yeah.
So going from that to unstructured, I think there'll be a challenge.
Well, for those of you who follow our work at the Weitzman Institute and know that we're shameless about taking any opportunity, you might see a webinar on what to do in retirement because I think
a lived experience.
It's a lived experience. So we may see more of Dr. Lecce. And I want to just again, on behalf of the family of individuals who work here and who've been part of our history and patients in the community and civic leaders throughout the community, thank Dr. Lecce for his service, and we wish him well, but we will see him on Main Street often.
Thank you, Carl. Thank you for everything.
You're welcome.
This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.